Hello, everybody, and good evening if you are in that time zone, or good morning, afternoon if you're in another. And welcome to this session of the Alumni Festival on tackling the global epidemic of non-communicable diseases. Without further ado, I would like to introduce you to the star of the session, Professor Nick Wareham, who is the director of the MRC Medical Research Council Epidemiology Unit at the University of Cambridge, obviously. I won't say anything more because over the next hour we'll be finding out a lot more about you, Nick. So nice to have you on, Nick.
Thank you, Tolu. Nice to be here.
Yeah, great. So you've chosen the topic of the global epidemic of non-communicable diseases, including diabetes. Obviously, we're all a bit more familiar with the concept of epidemics and pandemics, etc., and that's in this current day. So, working on something that is of epidemic proportions like NCDs, maybe if we start off gently by asking how you got interested in diabetes, and we'll get on to prevention afterwards, because this is something that doesn't get a lot of airtime. So can you tell us a little bit about your interest in diabetes?
No, absolutely. So I trained in medicine in London and did typical house jobs there and junior medical rotations with a view to becoming a clinician. And when I was doing diabetes actually at Guy's as a specialty, I was on the team led by Harry Keane, who was a very eminent diabetes researcher and an epidemiologist. And he instilled in me a sense of injustice about the complications of diabetes. We had patients on the wards with blindness, people who had end-stage renal disease, people who had amputations, and he was forthright in his opinion that these were preventable conditions. And that was very formative for me in focusing my attention both on diabetes and prevention. And I also felt that a disproportionate amount of money and intellectual thought and energy was being placed on dealing with the complications of disease, which our hospitals are well set up to deal with, and that's quite right, and we need to do that better. But an insufficient amount was being focused more upstream. Yeah. And I guess the thrust of our discussion today is that journey upstream. Yeah.
Because you were part of, you mentioned clinical training, but obviously like me, you're a public health trainee. So did that training also inform your thinking of going upstream in that way?
Absolutely. So I went to the London School of Hygiene and Tropical Medicine, studied preventive medicine there, and I've pursued a career which has tried to have a dual path, both thinking about the problems of diabetes as a clinical disorder that affects individuals who need individual care, but also as a public health doctor trying to deal with diabetes as a societal problem to address it in that way.
So we'll come back to talking about getting your thoughts on the prevention side of things and kind of getting action going on that. But you mentioned diabetes as a big societal problem. Just how big a problem is it, and why should this be something that we should worry about?
Sure, I've got some images to illustrate that. You mentioned that diabetes was an epidemic, and it's an epidemic that is somewhat silent compared to the epidemics we talk about in the news every day at the minute, but it's probably much more important in health terms. So in the United Kingdom, you see on this slide, the prevalence of obesity has been rising steadily since the 80s. And alongside of that, the prevalence of diabetes has been rising from around 3% to nearer 5% now. And across the last 20 years, Diabetes UK estimates that the prevalence, the number of people with diabetes has more than doubled in the UK. And they're now, close to 4 million people with diabetes. And that's a mix of, the reason for that is a mix of different things. It's gone up because people are living longer with diabetes, so that's a good thing. It's gone up because we're finding diabetes earlier, which is also a good thing. But it's in part going up because the incidence, the rate of occurrence of new cases is going up. And I think we are fortunate. We have a great healthcare system that's pretty well funded, but 10% of our NHS budget is spent on people with diabetes, and we can barely afford it. And the problem globally is that there are 463 million people with diabetes in the world. And 90% of those live in low and middle income countries. So we can barely afford it with a relatively low prevalence. So our prevalence is in the low region here, around 4 or 5%. But there are many countries in the world where the prevalence is double that. And India, China, are countries where the prevalence has changed very rapidly, and yet the healthcare systems are really ill-equipped to deal with this. And there are very marked differences in prevalence around the world. And there are some populations, maybe we'll come back to talk about it, the one at the bottom, Pima Indians in America, where 50% of people have diabetes. And the sort of overwhelming hypothesis is that there are particular populations which are particularly susceptible, be that through their genetics or early developmental risk factors. And that when you combine that with changes in behavior, physical activity and diet in particular, that drives the diabetes epidemic. So in the UK, those changes in behavior have been relatively small and have occurred over a relatively long time period. So this is a graph of changes in physical activity in the UK. In the dark solid line is actually TV hours watched per week. This element here, the big element, is the amount of physical activity. This is leisure time at the top. The next one is travel. This is domestic life. And the big one at the bottom in terms of energy expenditure is what we do at work. And across a period from 1960 to about to now, the amount of physical activity a week this is a measure of overactivity, has gone down from 216 net hours a week to something like 153. So quite a big shift proportionately, but over quite a long period of time. And you'd expect such a shift to sort of give rise to about a doubling in the risk of diabetes. But if we look at what's happened in China, it's really stark. So the time period is condensed. So not looking at a graph from 1960, but rather one from 1990s. And the scale is completely different. So in China, it's estimated that average energy expenditure has gone down from about 399 met hours across literally, a decade or so to considerably lower than that, 213. And you would estimate that would give rise to something like a 5-fold increase in diabetes risk. And that is actually what happened. So diabetes used to be really uncommon in China. But over the course of a very rapid period, driven by these big changes, both in diet, but also changes in diet through here, big changes in low and middle income countries in consumption of meat, that they are driving rapid changes in behavior and rapid changes in diabetes risk.
So two things really stick out on what you just said. Well, three things I think that were astonishing. One, that from the NHS perspective, the 10% of the expenditure is on one disease. I mean, that is just phenomenal. So when we talk about protecting the NHS, we really need to be thinking about how to address that. So that's one thing that strikes me as most remarkable. The second is around the proportion of cases in the world in low and middle income countries. I mean, that's phenomenal. And thirdly, the pace of change. One of the questions that Garth Wilkinson's asking related to that is, are you surprised by that? Because aren't diets relatively healthy particularly in Asia and in India, and isn't physical activity much higher than say we see here in the UK? So
I think that may have been true in the past, but there, as maybe we'll see a bit later on, things are changing very rapidly, and physical activity has changed drastically in China for the good. I mean, it would not be, we would not want to turn the clock back and have people have to be very physically active in their work. It's that because it is about development and progress, but that comes at a cost. And I think as we talk a little bit later, that really the crux of the matter is how can we find ways of helping countries that are developing do it in a sustainable way.
And a different trajectory to what we've taken here.
Absolutely.
Yeah. So we'll come back to talking about that behavior, the link between the behavior and the environment, because I'm going to ask you a question that is one of my bugbears. But before I do that, you mentioned particularly around physical activity and things changing. You studied that in quite a bit more depth as part of your PhD, didn't you? So can you tell us a little bit more about your findings from that?
Yeah, absolutely. So I was fortunate, actually, just before my PhD, I got interested in physical activity when I was a Harkness Fellow at Harvard, and was able to travel around the US and visited the National Institute of Health research team in Arizona, who study the population that had the highest prevalence of diabetes in the world, the Pima Indians. And the Pima Indians are a Paleo-Indian culture who live traditionally in this land of the Pimeria. And some of them live in what is now the United States, and some of them migrated further and live in what is now northern Mexico. So they're genetically identical people who are equally susceptible to diabetes, but they live in different socioeconomic circumstances. So if we look at the prevalence of diabetes, it's 50% in the Arizona Pima. So this is quite stark. This is a disease that, if it's not treated well, shortens your life expectancy by 6 years and has many complications. So this is very drastic. So the Mexican Pima, the prevalence in genetically identical people is much, much lower. It's still quite high relative to Caucasian people living in the UK, for example, but it's nowhere near what you see in Arizona Pima. And they are, the Arizona Pima are a particularly high prevalence of obesity. 70% of adults are obese. And if you ask them what they do through physical activity questionnaires, that there are big differences in occupational physical activity. So that the Mexican Pima populations tend to lead a traditional lifestyle in terms of being farmers and have a high level of energy expenditure and work. The Arizona people if they have jobs, they tend to be sedentary. So I got interested in physical activity at that time because this was useful, but it doesn't tell you what to do, because as I said before, you can't turn back the clock. You can't tell the Pima Indian you need to be out in the fields, reaching out in existence. So it begs the question, how much is enough for metabolic health? Do we need to be encouraging people to be fit and run around a lot and vigorously active, or is just walking enough? So I did the very first global study, a very large study of using wearable technology to assess physical activity objectively, and put people in quintiles, fifths of the population in terms of total energy expenditure, and related that to a measure of diabetes risk. And you can see that people who are spending the most energy in their lives have by far the lowest risk. And the people at highest risk are those who are in the totality of their lives spending less energy, and was able to estimate that a difference, if we were able to encourage people to do 20 to 30 minutes extra of walking a day, that would give rise to a 14% reduction in risk of diabetes. So that's what my PhD was about, and how we took on things from there.
Yeah. Maybe if you go back to that slide, Nick, I'm wondering whether what you found in terms of why the energy expenditure was different. So was it with people that had more energy expenditure, was that work related? Was it different types of work, or what domain of physical activity resulted in, what were the differences there?
Actually, this particular study totally wasn't able to address that. Objective measures that tell you about the totality and the physiology, they don't tell you about the domains of life. And it's probably, I mean, most of us have physical activity levels to which we're insensible. We don't know how active we are. We know what we do that is planned, programmed, and repetitive. So if you go to the gym on a certain day and do X and Y. But actually, most people don't know how much general walking they do, how many times they use the stairs. But that's kind of changed in the last 20 years with the rise of wearables, and people are much more aware now of that.
Yeah. So this might come in what we talk about next, but anonymous attendee wondered about what you thought in that particular study, whether that could be attributed to, those differences could be attributed to environmental factors and social policies differences between the Mexican and Arizona Pima populations. Is that something you looked at, or either in that population, or have you looked at since?
Sorry, I'd repeat the question or paraphrase it. Just
so whether the differences between those populations and physical activity could be attributed to environmental factors and social policies. Sure. So, for example, Mexico places a much greater emphasis on supporting indigenous populations than the US, for example.
Yeah, I have to, I don't know. And I think it's slightly a bit of an indictment on science that, and it's been challenging for people there. I was there as an observer, but the people there studying and working with the Pima Indians, that I think that their focus has been on explaining and has been quite biological, looking for a magic bullet biological explanation for things. And there's possibly been less attention to asking broader questions of why things are, and going beyond the individual and genes to thinking about people in their environments and how that might be changed. And that is challenging. And as you and I know, that's something we've tried to avoid, and how some of our science has developed. Yeah,
I think that's a really excellent question. I hope towards the end we can talk about how that feeds into interdisciplinary work, because that's it's essentially the point. But maybe pivoting off that last question, we're thinking about the context. Obviously, that wasn't a particularly different context. Can you tell us about work that you've done a bit closer to home on that topic? So looking at diabetes risk in the European context.
Yeah, absolutely. So thanks. So I was fortunate, and it is fortunate, to work on a big European study called EPIC. It's actually a cancer study. So set up in the early 1990s, involved nearly 500,000 people who were recruited in different sites in 10 different European countries. And it had been set up to study different risk factors and how they relate to the future risk of cancer. But I overlaid on it a study of diabetes. And that, if you want to do that, you really need some key attributes of a study. One is it needs to be large. Well, this was big. It needs to have long follow-up. So this had that, and we amassed about 4 million person years of follow-up. And that means we could find 12,500 cases of people who became diabetic after we collected the baseline information. And that baseline information was standardized for diet and activity, and we had stored blood. But also, one of the other things that was key about this is what I mean by exposure heterogeneity is that not everyone's the same. In an observational study of this type, if everybody is the same, you can't find out differences in risk between people. So if you want to study diet and physical activity, you have to study populations that are different. So you know, having people from Southern Europe, like in Sicily or Southern Spain, they're very different diets to people in Northern Sweden or Denmark, so, and Norway. So we had exposure heterogeneity, and then, you know, we had fantastic buy-in. You know, we ran one of the British elements of this, which had 25,000 people from Norfolk in. And these are, you know, you can't do this type of science without participants who are really engaged in it, not for what they can get out of it, but for what they can contribute. So they are a crucial part and the foundation of the team. Then you have to have great science teams across the UK and across Europe as a whole. I just want to say that also you need great leaders, and I benefited from, you know, working with Nick Day, Sheila Bingham, and Katie Core here in Cambridge. And Nick Day actually supervised my PhD, and he taught me a lot of things about science. He taught me some things what not to do. So he told me that if you ever have your photograph taken in Addenbrooke's concourse, make sure you know what you're standing in front of, because you do not want, if you're engaged in a study about diet, to be photographed in front of Burger King. But seriously, you know, colleagues like Soren Braga have used this to study the relationship between physical activity and diabetes. And generally, across countries, everything lines up. And we can see that for one category difference in physical activity, there's about a 13 or 7% in women difference in risk, which exactly lines up with the prediction from the PhD that I mentioned earlier. Also studied diet led by Nita Furi, showing that dairy products are beneficial for diabetes risk, fish is beneficial, and particularly fresh fruit and vegetables are beneficial. But some things are adverse, so people who consume more meat have a higher risk of diabetes. And we also showed an association, which I think we'll come back to, between drinking sugar-sweetened beverages and diabetes. So people, for a difference of a can of Coke a day, there's a difference of risk in 20%. So a small difference in consumption of sugar-sweetened beverages, quite a big difference in risk. Wow. And we also study the combined effects of genetics and obesity. And genetics are important. So across here, this is the risk of diabetes. Each of these is a quartile of people who are at higher risk. But then we grouped it by obesity. And so the black lines are people who are obese, the blue are the overweight, and red are the people of normal weight. And you can see if you're genetically high risk but are a normal weight, the risk is very low. And if you're obese and not genetically prone, the risk is very high. So yes, genetics is important, but it's the behaviors and diet and physical activity and obesity that really drives this problem.
So that maybe that directly connects to Gabrielle Oxley's question, asking about the biological data that was collected as part of that Interact study, and specifically whether any epigenetic data.
Yes, yeah, we have. So by epigenetics, we're making a distinction between fixed genetic effects and then epigenetic effects are effects around the genome that are modified by the environment. And we have seen it in Interact, particularly in the study that we did in Epic Norfolk, a relationship between epigenetic markers, particularly methylation of the genome, and diabetes. But it appears to be a consequence of the obesity, so it's linked to obesity.
I think that's really, really interesting. We're creeping into the complexity, which I'm particularly excited about. I'd like to tie in anonymous attendees' question about the correlation to artificially sweetened drinks with your next point around sugar-sweetened beverages. So perhaps if you could just incorporate that, the artificial sweetening in the context of sugar-sweetened beverages, because at the end there you mentioned about that quite stark. Every glass of cola makes it a significant difference. So You mentioned earlier when you were talking about your PhD, what I summarized is you saying is the indictment of inaction. So it's quite a significant problem. So how do we start thinking about research that moves from the observing and from the kind of recognizing what the risk factors are to evidence-informed approaches to actually intervening?
Okay, so that's obviously a very challenging question. I think the first thing, Tolu, is to set out to do it. In other words, to accept that it's observing and explaining is not enough, but that we need to give as much attention into thinking about what it is we're going to do about the problem. So we have engaged in that. So we did a study, a long time ago now, where we looked at diabetes risk in a previously unscreened population in Ely in Cambridgeshire. And at that time, 16.8% of those people had pre-diabetes. Now that's an observation. We didn't do anything about it by way of thinking about an intervention.
What do you mean by pre-diabetes, by the way?
Well, it's not a term I particularly like. So
neither.
Essentially, these are people with intermediate levels of hyperglycemia. So 11.1 is the cut point for diabetes. So these people here have prevalent but undiagnosed diabetes. But this is a continuously distributed variable. So it's not like there's a group of people with diabetes over here on the right and everyone else is normal on the left. It's a normal-ish distribution. And that the WHO defines these people here as having an impairment of glucose tolerance or pre-diabetes because they are at higher risk of diabetes. The fortunate thing is you can do something about it. So what we learned from trials in America, so this is a randomized trial where people with that condition, pre-diabetes, are randomized to nothing, placebo, or to an oral drug that's usually used for diabetes, but here has been using to prevent diabetes, metformin, or lifestyle in blue. And you can see that the lifestyle intervention does even better than the drugs. So the people on the lifestyle arm here, that's changes in diet and activity, had half the risk of diabetes of the people who've got no intervention. And this has quite rightly led to people saying, well, we need to do this. And Simon Stevens has been vocal in getting us to try and invest NHS money in a diabetes prevention program in the UK, which I am on the organising group for. And Simon's rationale is the economic one, that we are spending £10 billion a year on diabetes, and we need to shift the curve and think about prevention. The challenge for us in implementing that is really a classic one about the gap. So what you measure in clinical trials is efficacy, is how well something works under ideal circumstances. And whenever you translate that into the real world, you get a gap, and things don't work quite as well as they do in clinical trials. And there is a big gap in diabetes prevention. So we need to understand what that gap is and how to operationalize efforts to try and narrow that. But the other consideration is about approach, because that sort of find people with pre-diabetes and focus on them is a very individualistic, high-risk approach to prevention. And we need to balance that with an alternative strategy. And I just give you a reason why. So in the trials for diabetes prevention, they aim at 5 behavioral targets. They aim at, which is getting a normal weight, being physically active, eating a diet that's rich in fiber, and low in total fat and low in saturated fat. So 5 behavioral targets. And you can see in the intervention group, if you don't do any of them, the risk in those trials is 40% of progression to diabetes. But people who are doing 4 or 5 of those behaviors don't have any risk of progression to diabetes. So that it tells you that those behavioral targets are the right ones. But those behavioral targets also apply to everyone else. So if you look in the whole population, and this is what we did in the UK, people who are not reaching any of those targets, the risk is relatively high compared to people who are achieving more of them. It's nowhere near as high as it is in people with pre-diabetes. But, you know, the really positive thing is, this is in a follow-up study in Epic Norfolk. Not a single person who was achieving those 5 behavioral targets went on to get diabetes in during follow-up. So we know what to do. The question is how to do it. And if we focus in on very high-risk groups, it has a very low impact on this technical thing called a population attributable factor. So high-risk prevention is very sensible in terms of lowering risk for the small group of people for whom it works. But this measure here is like a measure of the potential impact on the overall epidemic. So it has a very small impact. Whereas if you try and intervene, if you can, on much larger sectors of society, like everyone who's sedentary, they're at much lower risk individually. But when you amass a small reduction in risk across a large number of people, you get this massive impact on the epidemic. So this is a sort of example of Jeffrey Rose's strategy of preventive medicine, that as a complement to thinking about high-risk approaches, which are perfectly okay, we also need to think about how can we shift distributions to the left for everybody, not just for finding people at high risk, and trying to push that curve as a whole to the left. And Rose told us it was a good thing to do. So he was a very eminent epidemiologist. I don't know if he taught you at the London School, but he certainly taught me. But and he wrote a fantastic book, which if anyone gets a chance to read it, is well worth a read. And it's actually, this edition is edited by my colleague Katie Corr. He told us this was the right thing to be striving to do, but his book tells us nothing about how to do it. So I think for our generation, that the real challenge is, what are we going to do that might shift that curve to the left? And that's why we set up CEDAR in Cambridge, the Centre for Diet and Activity Research, as a real effort to try and think about that evidence base and to move beyond thinking about these problems as individual problems, coming back to the question you raised originally, and going beyond that to think, well, physical activity is not just an attitude and preference thing about individuals. It's about the context we live in, you know, be that the school or the workplace, or more broadly, the transport policy for the country, or the physical environment of the place we live in. And that means doing a different type of research. So CEDAR, you know, we make an observation such as the one about sugar-sweetened beverages. We'll leave aside the artificial sweeteners. That's a technical issue. But, you know, across the world, you see this strong association. There's nothing nutritionally advantageous to drinking sugar-sweetened beverages. So we, you know, accumulated evidence from around the world about possible ways of addressing this problem and presenting that to the politicians. I think our interventions, scientific, made a little bit of difference. Probably the bigger difference came from, you know, Jamie and other people who had a much higher profile, which is just fine. But in the end, you know, a sugary, soft drinks industrial levy was introduced and is having an effect. So, and we're now evaluating that. So we're also thinking about the broader environment. So, you know, in a study, we've looked at takeaways and the number of takeaways people pass as they journey between home and work, or they used to when they went between home and work. And in this study, which is in, you know, rural Cambridgeshire and Cambridge itself, on average, people pass 32 takeaways, but some people pass as many as 165. And the number of takeaways you pass, you put people into groups of that. The top 25% here in Q4, their body mass index, the measure of obesity, is 1.2 higher than people in the lowest quartile. And that's independent of other factors like socioeconomic status, etc. So just being exposed to an environment that's encouraging fast food takeaways is strongly related to what people eat and their obesity. And then you have to do something with that. So you could, at that point, just report that and go home. But Tom Burgoyne, who led this work, has created a tool that's called FEAT that allows local authorities to map their own areas. And that has been very influential in places. There's just one illustration, like in Wolverhampton, in helping the local authority regulate the proliferation of fast food takeaway stores. So a very different type of research that studies these broader determinants of behaviour, but also seeks to interface with policy.
Well, you have piqued a lot of interest. I was going to interject to give you a quiz on why, if I said I dislike immensely the word lifestyle, and why is that? Because he used that word. But you kind of evolved from that, and the clue very much is in Brian Stoker's question, because he says, really recognizing where you ended off there, that many of those dietary factors are in the hands of food manufacturers. Sure. So what can be done about the industry? And you've given an example, certainly about from the local authority perspective, and how presumably just knowing what is happening on the ground is an important start. I'm going to lump in as a second question with that.
What was the question there?
Oh, so what to do about the huge industry that is increasing the unhealthy foods that are easily accessible, and increasing the risk of obesity. And a related question from Jeff Lester points out that Public Health England was a champion of such preventative measures. He doesn't mention them, but it's structurally changing. He doesn't mention this, but as you know, Public Health England has a Healthy Places, and they're really doing a lot of work around supporting local authorities and bringing together public health and urban planning. So can you just share some thoughts on that? There is even another one that says, is it possible to persuade takeaways to provide healthier foods? So can you give a response in there with those three questions?
Yeah, sorry, it's difficult to do this and look at all the questions. So
no, I've got you.
You're doing very well. So, I mean, we walk a very careful line in centres like CEDAR. We think it's our job to be evidence-based and create the evidence about what might work and what is working, but not, and to talk to people who are advocates and who are promoting a particular view, and talk to policymakers. But it's quite a fine line. So in terms of, we work very closely with Public Health England, and we will work very closely with whatever is the successor of Public Health England for population health improvement, to provide the evidence base of what works and what doesn't work. I'll give you one example. I think the soft drinks industry levy is a really clear example, because when we set out to do research on fiscal interventions that may impact on reformulation and sugar sweetened beverages, some people said, well, there's no point doing that. You shouldn't do it because no one would countenance that politically. And my response is, well, you don't know that, because that may be true today, but if we generate the evidence and are dispassionate about it, who knows, maybe the political opportunity will come along. So I think that it's, that we also have to understand better how to operate in that interface between science and policy. Actually, that's what I studied in my year at Harvard back in the 1990s, because some scientists think we live in a very rational world. We just find something and then we'll talk to a policymaker and it'll happen. And it is, as you know, it isn't quite that simple. Yeah. But the policy world is rational. It's just a different rationality. And we, in the CEDAR work, we've really worked very hard on trying to help researchers understand that policy world. And it has been tremendous. I mean, the guy I mentioned, Tom Burgoyne, he, a relatively young researcher, operates as a very good researcher, but is able, he was appeared before a parliamentary select committee and took questions and dealt with it brilliantly. So we've equipped people to do that.
Yeah, I guess it's recognizing that, that science policy interface, we need to take a population level approach in the science world, insofar as not every scientist wants to, there's a spectrum, right? And so as long as some of us are doing that, not everyone needs to.
No, sure. And
yeah.
But it's not innate, and you have to know how to do it and be trained to, and be given space and permission to do it.
Yeah. I'm going to pick up on that point just now, but I think it was just a point of clarification from Shelley, and I think that related to when you were talking about moving the curve to the left.
Yeah.
Are you talking about preventing diabetes, or are you talking about reversing diabetes? So is once you had diabetes, is type 2 diabetes reversible through diet and I'm not going to say lifestyle, even though that's what Shelley says.
But your aversion to lifestyle is the same as mine as a word. And I tried to show an evolution, because the point about lifestyle is it implies it's a choice. And it is probably better for us to talk about behaviors.
Right.
Because it's a more neutral term. I agree with that. So diabetes can go into remission if people have a very low calorie diet, and that's best done early in the time of them having diabetes, and that's an excellent thing. And we have some very good examples of patients here who if they take drastic action and lose a lot of weight through a VLCD, early on they can reverse
VLCD?
Very low calorie diet. But and that's great for those individual patients. But in order to really deal with the consequences of diabetes, we need to be thinking about the whole population. This is not a disorder that you can deal with one at a time. And maybe as a segue, if it's okay, it's really not a disorder that you can deal with one at a time in developed countries. I mean, we can just about afford a diabetes prevention program here, and we can afford So I was going to segue to that just with a couple of points, because I think you mentioned really early up front about just the burden of disease of diabetes globally. So just to keep tabs on that, I know, for example, some of the things that you've shared, you've talked about we can't afford it. There's some evidence from South Africa, which is an upper middle income country, that shows that just treating cardiometabolic disease would bankrupt the health budget. We know that. And this was the point that was asked about in India and Asia around behavior change. So maybe just as a segue to thinking about the global picture, just to kind of calibrate that, I think it's something like children in South Africa have the highest intake, or the second highest intake, of sugar sweetened beverages globally. So can you just tell us a little bit about that thinking in that big picture, because obviously impacting diabetes at scale globally? Well, I guess what I was trying to say at the beginning was, if 80% of people, of 463 million people in the world, have diabetes now, live in low middle income countries.
Right.
Our priority in those countries should be to improve the healthcare systems to deal with those people with a clinical condition. The real challenge is thinking about prevention. So if you look at, this is a figure about the number of people with that pre-diabetes around the world. So there are another 500 million people around the world with pre-diabetes. So we might be able to afford a national diabetes prevention program where we find people at risk individually, one by one, and treat them one at a time. But if you sort of tried to do that approach in in low and middle income countries with poorly developed healthcare systems, which are already under strain.
Yeah.
It's just an untenable proposition. And, you know, you mentioned sub-Saharan Africa, and the problem there is that this is the continent where the prevalence of diabetes is rising quickest around the world. It's starting from a relatively low base, but it's rising extremely rapidly. And, you know, I think that this is why we are focused on thinking about prevention and population level prevention in African context, because individual approaches to prevention, which are like clinical care, but extrapolated to people at risk, really are untenable. And a key element of that is the type of research we do, which I hope we get to, but also it's about people. So Cambridge has been really good at developing people, not just on courses like the one that we run for WHO, which we've been running since 1981, but also through some of the colleges, our own college, Wolfson, setting up hubs in global health. And these experiences people have through education and training here have very long-lasting effects. So there's one of the individuals on the first course that was run here in 1981, actually by my mentor, Harry Keane, was Ala Alwan, who ended up being the Director General of the WHO in the Eastern Mediterranean region, and then went back to be Minister of Health in Iraq. And he credits the time in Cambridge and the learning he had as being formative in setting him on a career, moving from being a clinician to being a public health worker. And I have numerous other examples. Des Williams, my very first PhD student here, is now CDC's chief man in West Africa, leading on Ebola. And Felix Asser, you know, came to Cambridge, attended the seminar, did a master's here and a PhD. And he says that this whole training has been invaluable to getting him started in research. And you know, he did studies in Cameroon using objective measures of activity, showing that this shift in the physical activity between the rural areas in green and the urban areas, which is driving metabolic risk. So that's why we've prioritized this. We've helped with capacity building, and as you know, we hope to do more in research.
Yeah. So I really want us to get to talking about the work that we're doing globally, because as you know, that's very close to my heart. You mentioned about the rate of increase in diabetes prevalence in Africa. There is also the opportunity in prevention, because obviously it's also a very young population. So there's, you know, the median age in Africa is 20. So there's a real opportunity there, and it sounds like this research is really timely, she says, obviously being involved in it. So can you tell us a little bit more about, particularly you mentioned the rural to urban transition. So as you know, is something that I'm particularly interested in. So, you know, how we think about those upstream factors globally. So tell us a bit about GDAR.
I think what we've been trying to do, and you've been at the very forefront of this, is to take a leaf out of what we did for CEDAR and to try and do that in a new center called GDAR, or Global Diet and Activity Research Group, where we're trying to support sustainable prevention of NCDs by not only thinking about what are the determinants of diet and activity, going beyond individual factors to the wider societal ones, in the context of a continent that's rapidly urbanizing, that is very young, thinking about how do we develop and or evaluate interventions and informing policy. And I think we have time, because I just checked on the clock, but if it's okay, I'd like to just show a video which really captures the essence of what we're trying to do and harks back to that early work we did in Yaoundé.
This is Yaoundé, a vibrant, growing city in Cameroon, undergoing rapid urbanization, which has incredible benefits, but also brings with it challenges, in particular, a rise in non-communicable diseases.
1 generation ago, most of the diseases you'd find in hospitals would have been things like malaria, typhoid, or intestinal tract infections. Within this context of uncontrolled urbanization, people tend to be exposed to unhealthy diets, pollution, smoking. They become less physically active. All these factors expose these people significantly to develop cardiovascular disease, diabetes, high blood pressure, cancers in their lives.
GDAR is a research partnership. It's funded by the NIHR. We focus on the societal determinants of non-communicable diseases, factors in the environment and in policy that impact on what people eat and how physically active they are. We also focus on designing and evaluating interventions to address those environmental determinants and address long-term health.
For me, I don't usually go and eat fast food. When my friends decide to go and eat fast food, I go with them. Because so many of them contain fat and it's not good for our health.
The trend of the increasing non-communicable disease epidemic is a very worrying one in terms of affordability. We know that the context of many countries in Africa, like Cameroon, is that the health system is already overburdened because we actually want to prevent that burden getting to the health system.
What we have been doing with adolescents in schools in Yaoundé, we are adopting what is called the citizen science approach. The individuals in the community themselves collaborate to cooperate with the researchers in terms of collecting information, analyzing this information, and making proposals.
We use an app that essentially allows these young people on their phones, so they capture their environment around their home, around their schools, and whether they see that as something that it enables healthy behaviors or is a barrier to healthy behavior. By analyzing their own data, the aim is to increase their agency to effect change and to engage with implementers of policy, planning initiatives. Really, those tools give them the self-efficacy beyond their individual health into the wider population.
For these students, they actually feel ownership. They are the ones who would collect this data, analyze this data, interpret, and design the interventions. The community actually feels ownership. They know best what would work within their context.
We always think about NCDs within the context of how to diagnose, how to screen, how to treat. But moving from that to thinking about prevention being everybody's business is a huge disruption.
We hope that these interventions will be more sustainable in time because it belongs to the community in which it is applied.
We don't have the time to all learn from scratch every time. So it's really important that what is being learned, what is being understood in Cameroon, in Yaoundé, we share experiences with another city that is similar in those contexts.
Thanks, Nick, for that. And just to flag to everybody, if you wanted to watch that again, because it was so enthralled by it, there is a link that has been pasted in the chat there, because that was a partnership we had with the BBC. It's really interesting reflecting on your journey to this point, because watching that now, it seems like you've rectified to some extent that indictment of just focusing on the one aspect of diabetes risk. What I wanted to touch on again, in addition to science policy, which we've spoken about, was the interdisciplinarity and just what is needed in terms of thinking differently about research, how you ask research questions, and how you actually conduct research. So can you share a little bit of your reflections on that, particularly in this context?
No, absolutely. I think I think bringing perspectives from different disciplines to this issue is paramount. I mean, and within CEDAR, we put in place mechanisms to recruit and train people from very diverse backgrounds, people coming who'd had first degrees and early postdoc training not just in kind of obvious things like geography, but people coming from the law sector, from from criminology. So it's incredibly diverse, because we need those perspectives, because a medical and clinical perspective is important, but it's not sufficient.
Yeah. And the other thing that really struck me as you talk about GDAR is really the nature of global partnerships and the kinds of partnerships that are required, really recognizing that expertise doesn't just lie with us, but that actually in our partnerships with global research, we are bringing together people with particular strengths. So can you maybe touch a little bit on that partnership? Because I know the Wolfson College, for example, has got that thinking about this in terms of the interdisciplinary hubs, and has got a hub in global health, for example, and trying to address that. So can you speak a little bit about that?
When we set out to establish GDAR, we created a network of partners, and you always start from people who have bilateral trust. So that's kind of obvious. So many of them were people we'd worked with previously. So we saw Felix Assar in that film in Cameroon. We have similar colleagues working in the University of West Indies with whom we worked previously. But we didn't define what the research agenda was. We had a general notion of wanting to study upstream determinants, but the problems and the means by which we could work together to solve them had to be defined by our local partners. And that's a slow process. And it probably would have been quicker to have parachuted in and come in with our solutions and got something done. But in the end, it would have been ineffective.
Right.
I think I really believe in this partnership building, establishing networks based on trust and with things defined in terms of the problem and the possible solutions by the people who have to live with them.
Yeah. And I think Cambridge can play a really big role, certainly in convening, recognizing limitations, but also in creating that convening space. And I guess that's what I was touching on about with the Wolfson Global Hub, and actually having that platform.
No, Cambridge can definitely play a role, but it's a convening and a listening and a facilitating role, not a command and control role.
Yeah, yeah. So one final question, in one sentence, if you knew then what you know now, what would you do differently?
You know what, I'm not sure I would do anything differently, because I have been fortunate to be able to practice medicine as a physician and care for individuals, because we definitely need to do that, and that is a privilege. But I've also been able to live in a society that could afford to train me not to do that 100% of the time, and so I've been able to learn about public health and to take this broader perspective, which is a privilege, and not everyone has the opportunity. So I don't think I'd change anything, to be honest.
Great, thanks. I think that's an important reflection on
maybe in closing, when none of us ever does any of these things, in isolation, and I really should, thank the teams that I work with. So, there's a whole team that work with me here in the Institute of Metabolic Science, and it's a real privilege to work with all of them. So, thank you very much.
Great. Thank you so much, Professor Nick Wareham, and particular thank you to all the participants for all the questions. Sorry, we couldn't get through them all, but we aim to take them as we go along. So I hope you've learned a little bit more about non-communicable diseases through this, both locally and globally, and the population approach and why prevention is so important. So thank you very much for your inputs on that. As you know, there's still lots of the festival sessions taking place, so we hope that you are engaging with that. And I'll just leaves me to thank you all very much and wish you a lovely evening, day, morning.